So last week we were talking about the traumatic conditions of the chest, and we covered sternum and clavicle and a few of those things. Now we're going to get to some of the other traumatic conditions that you can get. Right. So hopefully going to teach you some tricks on how to look at it. All right. So simple rib fractures, something you'll see very common. All right. And the thing is, the nice part is plain X-rays will normally show you the fracture. So you don't need fancy CTs, MRIs, things like that, And just as a general rule, if you've got 1 to 2 isolated fractures, all right? So I mean, it's just single fractures, 1 or 2. You can normally treat them as an outpatient, especially if it's a young or fit patient. Basically, you see, the thing is, like I told you, the pain comes from the periosteum. So the problem with the rib fractures is that you have to keep on breathing. You can't, so you can't, for instance, you can't immobilize the rib. That's the sad part. Okay, so you have to explain to the patient it's going to take them about 6 weeks to heal. They are going to be in pain. Advise them not to sleep on that side. The most common thing I advise patients, put a cushion under the fractured side so that they don't roll onto it by mistake. And you're just going to keep on giving them analgesia. And if worse comes to worse, eventually you have to block off the nerve and things like that. I'm not going to cover that too much today, but that is something you can do. Once you get 3 rib fractures, regardless of the age, you really need to start thinking about admission. The reason being, because of the amount of pain that's occurring in the chest, the patient starts to splint, so they end up breathing with their diaphragm more because they don't want to move that chest wall at all. So then they're at risk of atelectasis, pneumonias, things like that. So you have to be a bit careful. And in the elderly or the frail, even 1 or 2 rib fractures can cause that. You have to be a bit careful. You have to consider each patient. Okay, and of course, ribs are often injured, but don't forget about other injuries, lung injuries, severe soft tissue injuries, cardiac injuries, things like that. Okay, so let's look at one. All right, simple fracture. Okay, so these are your ribs. So I know it may sound like a silly question, but which part of the rib is this? Front or back? Got a 50% chance of being right. It's the back of the rib. Yeah, it's the back of the rib, right? So a lot of people feel this is your rib. This is actually not your rib, the entire rib. So what happens is your rib goes there and then curves around. Okay, this rib is coming there and curving around and coming forward. But you can't actually see the front part all that well because of the amount of exposure that's put through on the X-ray, right? And then these are not fractures. I'm just letting you know now. Okay, for example, here, this is not a fracture. That's your costovertebral junction. I'm only saying this because I've been called a lot of times 2 in the morning. Says patients with 8 rib fractures. I'm like, what are you talking about? Like, look at it. I'm like, no, this is a costovertebral junction. Those are not fractures. All right? I'm just letting you know because it happens. I mean, it really happens. Sometimes people are tired, they're not really, and it happens. Okay. So this is, and then if you follow this rib, all right, so you're going around the posterior, and then when you come here, that's where you can see the rib fracture. Right? So I just want to put this on so for the people on Zoom, they can just see what I'm talking about. So the thing is, the rib is it's a shape like that, right? So that's basically what it is. So if you're going to break something that's shaped like this, it normally does this. So it fractures at the curve. It's more difficult to fracture it there or fracture it there. And if it does fracture there, it tends to fracture in 2 places, which we'll get to later. So any sort of U shape or bend tends to fracture. It's like a wishbone. It tends to fracture at that point. Okay. So just so that you remember that. So in other words, these are the most common areas for ribs to break. Now, it doesn't mean it always breaks there. It may break there, it may break there. But generally, the curve is the most common place. All right. So the thing is, it's easy now because, when like this patient now, they pre-mark their fracture with an arrow. Okay. This patient came in like that. All right. So what do you do if your patient didn't inhale an arrow and point out their fracture? That's where the problem comes about. Okay. So how do you make sure that you find this fracture? That's the thing. So let's have a look and see. All right. So let's try and find the fracture first of all. Okay, so it's on the left chest wall. All right. So try and have a look and try and find it and see if you can see it. So we know it's on the left. All right. So don't worry about the right-hand side. So what system do you use? That's what I'm asking you. So most people will use the system of trying to look at each rib, right, and try and follow it out, which is nothing wrong with. But once you start getting here, it starts getting confusing now. Which rib am I looking at? Am I seeing a fracture? What's going on? And tell me, can you see the fracture anywhere? Even by following each rib? You may well be able to. I'm not saying no. You may well be able to. But it's a bit difficult. Agree. It's not easy. And you've got this patient, for example, who's howling in pain, saying they're in pain, they're not feeling well. But yeah, a lot of, even myself too, even when I was doing this, I was also looking at it like I was squinting my eyes and trying to figure out if there is a fracture over there, what's going on. And there is a fracture over there. That's the thing. So I'm going to show you how you can have a look at it now. So you remember what I told you guys, when we work in the emergency department, you have to be quick and accurate, two things that don't go together. All right. So we have to develop systems that allow us to be quick yet accurate. All right. So I'm going to show you a little trick that helps you to look at just to look for rib fractures. It's not 100% that you'll see it, but you'll see it about 99% of the time. Okay. So what we do, let's flip this thing on its side. Okay. So what happens is when you flip it on your side, can you see that these ribs, they kind of form a dense, sort of where they all meet, right? So they form like a density, okay? And they should form a straight density. So if you follow this one, for example, can you see it makes a nice straight line all the way through? And when you start following this one and you come here, you can just see that line just goes off ever so slightly. Not a lot, but you can kind of see these two ribs kind of jump out of place, all right? And then when you have a closer look, now when you focus on where the jump is, can you see that rib? It doesn't look 100%. It kind of looks squished almost, all right? So there may be an underlying fracture there. And when you look here, there's a rib fracture over there. Okay, so by following this line, all right, this dense line, if I can put it that way, all right? And when you come and you notice that the dense line is slightly out of shape. So in this particular one, it's a very subtle fracture, but I wanted to show that it can still help you. It just kind of jumps out a little bit. Okay, not a lot, but just a little bit, right? So it may indicate a fracture, right? Wait, what did I write? If it doesn't, it may. I think I hit a bit of a problem with my English over there. All right. So what happens is the ribs may be pulled in or they may be pushed out, right? So when they are pushed in, what happens is generally you get intercostal spasm. So when you get that intercostal spasm, it pulls the ribs inwards. So the line kind of ducks in, right? If there's a fracture or damage to the nerve, the intercostal nerve, then you sometimes get paralysis of the intercostal muscle and it may move out. Not always. The more common is movement in, right? But you may also get severe fractures that cause it to move out as well. There's a lot of things that can happen, damage to the intercostals themselves. But I'm just giving you an example of what can happen. Right? So now when you look again and try to find it, it's much easier, right? So like I say, it can't exclude 100% of fractures. Maybe very minor fractures, linear fractures, things that we may not be able to see, but at least it gives you a nice way of looking at it, right? So what I suggest is if you do this and you're not really sure, then go back and check each rib individually, okay? And try and see if you can pick out something. But this is just a little way to help you out, okay? So we're gonna try another one, okay? So if you look at this, right? If you just look at this X-ray, now it may be quite obvious initially when you look at it, but let's have a look and see what I'm trying to explain to you. Right, so first, let's look at the left-hand side. Now, it's very obvious that the trauma is on the right here. All right? You can see a massive pneumothorax, a contusion, all right, things like that. So let's have a look and see. So when we follow this line, this dense line this way, can you see it's kind of continuous? All right, it's kind of continuous. You can maybe argue this rib is moved in a little bit and things like that. So if you're worried, you would maybe go back and have a look and see, but there isn't actually a fracture on this side. But let's follow it on the right-hand side. Now, when you look at that line, can you see how, let's say, non-continuous? I think that's the right word. I don't know. Non-continuous it is. In fact, here it jumps in quite a bit, right? So when you now go back and have a look at the upright X-ray, and now when you follow each rib, now you can start to see all the fractures that are occurring all over here, right? So there's 1, 2, 3, 4, 5, all right. 6 actually, all right, if you start from there. So there's quite a few, even if you didn't catch all of them. And there's an icy drain through here as well, so don't worry, that's what's poking out there. So even if you didn't see all the fractures, but you know that there's quite a few. Okay, this patient's got a pneumothorax, they've got a lung contusion, which we'll get to just now, all right? So this type of a patient, are you worried or are you not worried? Should be very worried because there's about 6 fractures that are going on over there. So first of all, to insert that icy drain is not going to be fun. I mean, to insert an IC drain without a fracture is not fun. Your patient's generally screaming and shouting. So imagine with rib fractures, and you're going to be trying to physically move those ribs apart, push a tube through. So this is the type of patient where you may even consider heavy sedation, even things like ketamine, dissociative anesthesia, things like that, just to minimize their pain, not only for the sake of putting in the IC drain, but just so that they can breathe. Okay, because at least it will allow them to move their rib cage without breathing. Okay, without feeling pain. Sorry, rib cage without breathing. Sorry. Okay. So what's a flail chest? So a rib that's fractured in 2 or more places. All right. So why is this a problem? All right. And specifically for the movement of the rib, and what does it mean for the underlying structures, and how do you spot it? Okay. So why is it a problem? That's the question. Okay, flail chest or flail rib, for example, if a rib is fractured in 2 places, the area that is now, let's say, furthest from your body, the furthest part, or the part that's now detached, is no longer contributing to respiration. Okay, so what happens is normally when you breathe in, your chest expands, all right? And the reason it can do that is because your ribs form a solid structure. Okay, once that structure is no longer attached or no longer attached to anything, as soon as you breathe in, right? When you breathe in, you're pushing a diaphragm down, you're creating negative pressure, you can draw air in. So that negative pressure pulls the rib in as well, the section that's no longer connected. So the section that's no longer connected can't expand that piece of lung that's connected to it. So that piece of lung is no longer being ventilated. That's why it's a problem, right? Secondly, pain, all right? Because every time you're breathing, that rib is now moving, touching, the periosteum is moving. And of course, it's going to damage underlying structures as well. So how do you spot it? So let's have a look. Okay. So, all right. If we have to follow the lines, you can. But this one here, it doesn't take a genius to see where the problem is, all right? So you can see these fractures all over here, all right? So when we say fractured in 2 places, you can see there's one fracture there. There is another one at the corner. I think it's just showing a bit bright on the computer at the moment. But you've got all these fractures that are going on over there, and then they were further fractured towards the end. In other words, all of these were flail segments, okay, this entire area. So what happens when the patient is breathing? So if you were to look at that part of the lung, when the patient breathes in, instead of it going out, it falls back down. And when the patient breathes out, it goes like that. So it's what we call a paradoxical movement, okay, or a seesawing movement. So that's how you can say that it's a flail chest, all right? So how do you treat it? What do you think you need to do? Chanel, you should know it. Hey, you should know it. All right, so the first thing is that area of the lung that is no longer attached to the chest wall is not ventilating that lung underneath. So even if immediately there's no collapse of the lung, it's going to take place at some point. Number 2, your patient is in a severe amount of pain, so they're going to try not to move their chest at all. So again, you get the diaphragmatic breathing so that they don't move their chest wall. Try and breathe like that for a minute. Just try it now. It feels unnatural, and you can already feel it. And you're not supposed to feel your breathing. So you're going to get tired after a little while. So they're not going to be able to ventilate effectively, even the side that's not injured. So how do you make sure you ventilate this patient properly? What do you think you need to do? What's that called? Intubation, very good. So majority of these patients need intubation. Not all. You've got a single flail rib, maybe even 2 flail ribs, you can still get away with it, all right? But once you go beyond that, for example, something like this, you need to start thinking about early intubation, ventilation, anesthesia, sedation, pain management. These are all the things that you need to worry about. These are the type of patients where we'd even consider doing intercostal blocks, all right? So you have an intercostal nerve that runs. It's the famous question in anatomy. They always ask, it runs inferior to the superior rib, all right? So in other words, if you've got 2 ribs, it runs there, all right? So it's a fancy way of saying it just runs below the rib, okay? So you've got your neurovascular bundle that runs there, okay? So basically what you would do is paraspinally, you would then attempt, now we do it via ultrasound so that we can visualize it. We basically inject long-acting local anesthetic into all of the flail segments, all right? So that cuts off the nerve supply to the periosteum so the patient can start to move that chest wall as well, okay? And it's not as painful. So some of the longer acting local anesthetics can last for 12 to 14 hours. So, you know, it is possible to do this on a daily basis and try and get these patients back to normal. The problem is that they have a lot of associated injuries, all right? So they have pneumothoraces, hemothorax, like in this case, pulmonary contusions, which we'll talk about just now. So these are patients that need ICU. They are going to go into respiratory failure very quickly, okay? You need to intubate them as quickly as possible, get ICU involved as quickly as possible. In most of our emergency departments, we have ketamine, for example. So you would do this under ketamine, keep them under ketamine, dormicum, morphine, things, those types of things, just to keep them sedated and keep them nice and comfortable throughout that time. Okay, right. Pulmonary contusions. So what is a pulmonary contusion? Essentially, your lung looks like a sponge, all right? So imagine bleeding into a sponge. So in other words, the blood's not coming from the outside. Imagine blood coming from inside the sponge, right? So what that blood is doing is basically blocking up most of the smaller airways, all right? It's blocking alveoli, things like that, all right? So this normally takes a large amount of force to cause, all right? So normally there's also associated injuries such as rib fractures, sternal fractures, things like that, all right? So I'm pretty sure there must be a rib fracture here somewhere, I think somewhere there. And if you follow the line, you can actually see the line jump out here, right? So this patient, most of these patients suffer quite severe trauma. Now, the problem is because you got air entering but cannot physically bypass the blood, you have what we call a VQ mismatch. What does VQ stand for? Excellent, ventilation perfusion mismatch, right? Which is a fancy way of saying air is entering but cannot get into your bloodstream, or vice versa. The blood cannot reach the air cannot reach the blood, right? So that's basically what it's saying. The thing is, it can be mistaken for a hemothorax. If it's a very dense contusion, you generally look here at your costophrenic angle. So in most of the hemothorax, you'll get what they call the meniscus sign, right? So in other words, it forms a meniscus, and in a contusion, it generally doesn't, right? And in a contusion, you get blood in your endotracheal tube. Now, why are we talking about an endotracheal tube? It takes a lot of force to cause a pulmonary contusion because it's a sponge. Hit a sponge. It doesn't. Imagine hitting SpongeBob. Right. They've been hitting SpongeBob for years. SpongeBob doesn't get hurt. Right? SpongeBob is practically indestructible because he's a sponge. Okay. So in other words, it takes a lot of force to hurt SpongeBob. Okay. So what I'm saying is that these patients generally have suffered quite a severe trauma, massive trauma. So there's often other injuries associated with that. Okay. So in other words, you'd have to take like a punch from Mike Tyson, for example. Right? Just to give you an example. I mean, like, I'm not a trained boxer. Okay, and imagine Mike Tyson came to punch me. All right, I would get a pulmonary contusion. Right, I can't outrun him. I'm not that bad. But you get what I'm trying to say, all right? Or a truck or a car, something smashing into you, a sledgehammer hitting you, something. It takes a massive amount of force to cause it. So these patients are often unstable from a lot of points of view. Right, so that's why we talk about an ETQ. Alternatively, they may just have hemoptysis. But I must be honest, if they're at that stage, you probably are already going to be intubating because they're going to be losing quite a bit of blood, right? And if you guys remember, when we talk about hemoptysis, what is dangerous hemoptysis? How much of blood? Not much, but 125 mL is regarded as life-threatening hemoptysis, just a cup of blood. But if you bled a cup of blood from your arm, nobody's really going to worry. We'll stitch you up and send you home. But a cup of blood, not even a cup, sorry, half a cup of blood, 125 mL from your lung is worrying, because what it tells you is there's a lot more sitting in that. Okay. I think it's 125, if I remember correctly. Or was it 250? No, it's 125. I think it's 125. It's a long time since I worked in the TB section, but I remember that they used to talk about it, right? So, pneumothorax. Okay. Now, in this case, you can see the anterior ribs very nicely, okay? But whatever the scenario may be, the way that you look at a pneumothorax is, number one, when you have a lung, you are supposed to have lung markings, all right? So these lung markings are actually the vessels that are passing through the lung, right? Because they are full with blood, right? So the blood blocks the photons from passing through. The air doesn't block it, right? And then when you get congestion of blood vessels, you get thrombograms and things like that, but that we'll get to later on, right? So if there are no lung markings, so look at this lung, this side at least. Can you see? the lack of lung markings. That's what tells you there's a pneumothorax. Right? Now, this is a massive pneumothorax. Right? The lung has collapsed right down here. So there's essentially no lung. Right. Now, if this was an open wound, that's all well and good. It's fine. It's a simple pneumothorax, air moves in and out. We've actually talked about it before in chest trauma. Okay. If it's a closed one, we'll get to it now. But your treatment is basically to get an IC drain to decompress the lung and let it, expand again. I'm more on the opinion that this is a tension pneumothorax simply because the trachea is being moved, all right, which is your first clinical sign as well of tension pneumothorax. Okay, all right. So let's find another one now. Okay, let me just hide this, which should give you a clue. All right. So it is there. I promise there is a pneumothorax here. Okay, because I like to show the easy ones. Everybody can see the easy one. The question is, what do you do with the difficult ones? That's the question. So follow your lung markings. So just follow. Look at your lung markings. All right, I'll give you, it is on the left-hand side. All right. So in other words, start following your lung markings on the right and notice how far they go out. All right. And then follow the lung markings on the left. And this is a difficult one. It's not an easy one. So if you can't see it, don't get stressed. Okay. I'm not trying to catch you guys out. I just want to show you that, it is possible to sometimes miss these things. Okay. All right. So in the interest of time, let's go through it. So have a look at these lung markings. All right. Specifically here. Can you see what happens? What happens when I reach about that point? In other words, what's happening over there? Can you see any lung markings? Once we go just past that point. Whereas here, when you follow, can you see the lung marking? Right. So in other words, if we were to actually have this X-ray physically in front of us, nicely in front of a light, a light box and things like that, we'd probably be able to see the pleura, which you can actually see just below the rib if you look really carefully. I can see it because I'm sitting right next to the screen. All right. So, but otherwise it's very difficult. In other words, if you were to look at this rib space, you can see lung markings. But if you look here, there's no lung markings. So that's where the pneumothorax is sitting. Okay. Now, if you had a patient, for example, with a stab wound that was bubbling, and even if you couldn't see this particularly, but the fact that there's bubbling means that there's a pneumothorax. If you had a patient who was maybe not saturating well, or you suspected, you really suspected because it's a deep wound, you can't say for sure on the X-ray, your other thing to do is an ultrasound. And if you can't remember how to do the ultrasound, the lecture is already there. You can go back and watch it on how you look at a pneumothorax, all right? But just to show you that they can be subtle some, all right? And it's worth it just to take a few seconds just to follow the lung markings. And sometimes you may actually notice that, hey, you know what, it's missing here. There could well be a pneumothorax, all right? Now, there are certain subtleties when it comes to pneumothorax. They say when it's less than so many millimeters, and so then you don't put an IC drain, don't do that. In the emergency department, there's a pneumothorax, just put the IC drain. I'll be honest with you, because by the time you keep that patient, do a follow-up X-ray after 4 hours, do this, you do that, you caught up with 10 other things, you're going to forget that patient is going to end up dying. So rather just put the IC drain in, it's not going to take that much of your time, and you know the patient is fine. Okay, the worst that's going to happen is the surgeon's just going to get angry with you the next day. That's the worst, nothing else. Don't worry. Okay, all right. Let's see, I don't know if I've got anything else. Hemothorax, very easy. All right, blood in the chest wall. Okay, as indicated by the big yellow arrow in case you didn't realize. Okay, and the way to treat it, IC drain. All right, when do you get worried? When the bottle fills up immediately. Okay, as soon as the bottle fills, consider this to be a massive bleed. Clamp the tube, patient needs to go for a thoracotomy in theater. The other, within 4 hours, for 4 hours, you collect 250 mils per hour. All right, so if you notice, in other words, it's filling up relatively rapidly. All right, so that means the patient is continuing to bleed on the inside. Okay. These are the types of things that if you forget the exact amounts, Google it, it will come up. It will tell you 250 mils per hour over 4 hours also demands a thoracotomy. Why do you clamp the thing? You clamp it so that you try and tamponade the bleeding a little bit. If you have one of the newer IC drain bottles, like those Sinapi ones, those you can actually retransfuse the patient. So you do an auto transfusion. So we basically drain the blood into that thing, you hang it up, put a bit of heparin, and it's actually got a port that you can put it back into the patient. It's amazing, but we haven't had a chance to use them because they come once in a while, and then we have the old bottle and things like that. But just so that you know, it can be done, right? Okay. So needle decompression, thoracostomy, right? You generally use quite a big cannula, so a green, a black, or an orange, right? You basically push it into this area, mid-clavicular line, second intercostal space. Feel for the space between the ribs, push it through. Okay. You listen for the rush of air, so you'll hear sound coming out, right? And how do you know you're in the right place? Your BPs will start to increase, your heart rate will start to slow down, your sats will increase, and your neck veins that were dilated will start to decompress because there's no longer compression on the heart. Okay, so that's for a tension pneumothorax. Okay, so IC drain, we almost done. Okay, so these are the borders that you look for when you're putting in an IC drain. So the lateral edge of the pectoralis, the base of the axilla, the lateral edge of the latissimus dorsi, and the fifth intercostal space. So basically anywhere here is the safe area to put in there. Okay, go anterior, you're going to miss. Go superior, you're going to go into the axilla. Go posteriorly, you're going to miss. And go inferiorly, you may hit the stomach, and on the other side, you may hit the liver. All right, so that's how you do it. So we're going to watch a very short video on how you actually put in an intercostal drain. Okay.
I'm Dr. Jess Mason, and this is a method for chest tube placement. Before you get started, make sure your patient's pain is well controlled and secure their arm up behind their head with tape or a restraint. I want to make sure this guy doesn't move. Once you're sterile, prep and drape a wide area to keep a large field.
Sorry, I'm just trying to start it again. I'm not sure why. Started off well enough. I don't know what happened.
I'm Dr. Jess Mason, and this is a method for chest tube placement.
Sorry.
Before you get started, make sure your patient's pain is well controlled and secure their arm up behind their head with tape or a restraint. I want to make sure this guy doesn't move. Once you're sterile, prep and drape a wide area to keep a large field visible throughout the entire procedure, from clavicle to costal margin, sternum to mid-axillary line. Then you're going to palpate down to the fourth.
I will post that video so that you guys can see it. I've actually got it saved separately because that's no use watching. It's like watching still frames. It doesn't make a difference. All right. So that's the end of the presentation. Like I said, I'll post the video as well so you can see it. But any questions or anything, because it's a relatively simple topic. It's not difficult, but it has some subtleties and it's easy to miss. Let's put it that way. But if you keep an eye out and you use little tricks to help you, you can actually make the diagnosis majority of the time. You know, use your ultrasound as well. You can actually sort out most of these patients. I love trauma. Trauma is easy. Medicine is difficult because you got to use your brain. Trauma, you just got to sort them out. Stop the bleeding, keep them alive. That's it. You know, medicine, you got to figure out what the bloody kidney is doing and what the heart is doing. Right. Okay. Okay, if there's no questions, then we'll stop it there. I'll post the video as well so that you guys can look at it, IC drain placement. She does it very well, and it's nice and high def, everything, so you get full HD at least, so you can see it properly. All right. Okay, so yeah. All right. Thanks a lot. And then yeah, we'll stop.